Next generation sequencing is really important for patients with sarcoma. There is more wide-scale adoption of NGS testing, but we still get patients that have never had NGS testing by the time they come to us. And, the reality is that NGS testing is unlikely to change, the first or second line treatment in these patients. However, there's always a possibility of finding something like an NTRK fusion, which has, really good treatments like repotrectinib, larotrectinib, and entrectinib. Furthermore, I find that we find actionable mutations that we may use down the line. At our center, we really do focus on patient outcomes, and sometimes due to the rarity of these tumor types, we will use the NGS reports to identify possibly off-label treatments that we can try in these patients. The reality is with rare tumors, we may never have data in some of these agents to know whether or not they work, but we're using them in the treatment refractory setting for patients that still wish to seek treatment but may be out of systemic options, and frankly, they may not be good trial candidates. So I think when we think of cellular therapies in solid tumors in general, it's been a big challenge, partly due to the lack of good targets and high toxicity. That's why, the approval of afami-cel last year for synovial sarcoma was really exciting for our community. And that's really targeting a marker called MAGE-A4, which is a melanoma-associated antigen A4. And like you said, it does require certain HLA types, O201 specifically. And this is really common in more Caucasian populations, and so therefore it limits the applicability. But I can tell you in my practice, I've had several patients with that ethnic background, and they still have not had those HLA subtypes. And so I think that we will need further studies and further drug development to address a wider population across the world. Specifically for ivosidenib, this is a drug that we have used in chondrosarcoma with IDH1 mutations. But it has actually not been studied in a phase 3 study. So we currently are conducting a phase 3 study for these tumor types called CL3, and it does use ivosidenib. And I think there is great potential there for approval in chondrosarcoma. I think there are certain molecular targets that are very promising. I think B7H3, which is currently being studied as a CAR-T up at UCSF. We have an antibody-drug conjugate trial that early results seem to be very promising. B7H3 seems to also be widely expressed in osteo and chondrosarcoma, and that's also being studied at several centers. So I think there's a lot coming on the horizon. I think in terms of immunotherapies, when we're talking about the checkpoint inhibitors, they likely, have little to no activity in the single agent setting. But one of the things that we do at our center, the Sarcoma Oncology Center, is we combine some of the existing therapies with immune checkpoint inhibitors and other immunomodulatory agents. And we find that we do have considerable success with that. I think multi-arm studies are really important, where we can perhaps take one of the standard therapies and treat patients with them, and those that progress maybe add one of the novel immunotherapies or a novel agent perhaps. With small populations with these rare tumors, it's hard to design trials and capture patients that are ideal for these trials at the right time. And I think multimodal therapies are really the key. We know these are really difficult to treat tumors, and, trying one agent at a time may not be the right approach. If you have a patient with a sarcoma, I highly encourage you to urge the patient to find a support group that's relevant to their specific subtype, or maybe a sarcoma support group in general. These patients need a community. They don't know other people that have this tumor usually, unlike, say breast cancer or lung cancer, where many people have been touched by this. And these are young patients that are desperate for new treatments and for hope. And that would be my message.